And thank you everybody for attending the conference. I'll try to speak fairly slowly so it gives everybody an opportunity to follow the conversation. If you speak English, I unfortunately don't speak any other languages, so I do apologize. And also it helps the interpreter if I pace my presentation fairly slowly. Just by way of background, as Justa said, is I started my career trained as a nurse and then a behavior therapist, working in both inpatient and community settings. My last substantive post within the health service in the UK, the NHS, the National Health Service, I was a chief nursing officer, a director of nursing, and I'm going to share my experiences of being involved in a hospital closure program where we set up an intensive support service in the community for people with mental impairment. So dual diagnosis of intellectual disability and additional complex mental health problems and offending behavior. So I'll tell you a bit about that service, what went well, some of the challenges, and then there'll be some time at the end for you to ask questions. So I'll just share my screen. Okay. So it's a very personal reflection. Back in 1990, I was part of a specialist team tasked to close a hospital. And like many hospitals at that time, certainly in the UK, there was a whole mix of patients. Some had been in the hospital for their entire life. Some had shorter stays. Some patients were just institutionalized and presented no risk to the public whatsoever. And some patients had had some contact with the criminal justice service and maybe presented a risk to the community. And I think the biggest challenge is trying to figure out who presented a risk and who didn't, because one of the difficulties we had when we started to look to set up the services, if you've got a patient, let's say, for example, with a history of sexual offending behavior, or at least sexually inappropriate behavior, they may not have come into contact with the criminal justice service. It's very difficult to assess the risk when the patient lives in isolation away from the community and isn't exposed to the opportunities. So one of the biggest challenges was to decide what was the actual risk in the first instance, because it was almost like an artificial decision-making process. But we set up a service. No, there we go. So I trained and worked in a typical large Victorian institution. The hospital where I worked was opened in 1890, originally as the local asylum. Eventually, when I trained, there was 3 sites across the city, and we had approximately 2,000 inpatients. And the important thing was the hospital was very isolated. It was 15 miles away from the city itself, and very much of the era out of sight, out of mind. I guess for the general community, what you didn't see, what they don't know about, didn't concern them. Nobody really cared what happened behind the walls of the hospital. There'd been across the UK a number of inquiries related to abuse of patients, but these were few and far between. But generally, I guess there was a culture within that hospital, and I don't think it was a culture that anybody decided to create. It just existed. And on one side of that culture was the staff. We had the rights, we had all the power, all the control, and on the other side we had the patients. So it was very much us and them. And in any environment where you have a culture of us and them, you really create the right conditions for abusive practice. And not only in the hospital where I worked, but in multiple hospitals all around the country, there was poor care, neglect, physical abuse, financial abuse, coercion, restrictive practices, sexual abuse, homicide even. The hospital where I worked, you know, in order for me to get funding to go and train as a behavior therapist after I qualified as a nurse, I'd been asking and asking, and I was told no. And then we had 2 murders within the space of 6 months, where patients murdered other patients. And there was a big inquiry, and then all of a sudden, there was a lot of money poured into the hospital, and you know, I took that to my advantage, and I asked if I could get funded to go and train to be a behavior therapist, in which I was given the funding. And then with a colleague, we decided to set up a training package, because we felt one of the problems within this culture is there was very little education and training provided to the staff, and the staff who were working with the most difficult, challenging patients had you know, there was some qualified nurses, but the majority of staff were support workers. They didn't have any professional qualification. So we decided to set up a training package. And we started to train initially staff working in the forensic services. We developed our own package of training, helping staff to understand why patients behave the way they did, particularly understanding factors associated with distress and conflict, teaching staff how to manage conflict effectively so that we could prevent escalating behavior, and ultimately we could prevent staff and patients putting themselves in a position where people were going to get seriously hurt as a result of aggression and violence. And then the other side of the training, because aggression and violence and hostility did arise, I mean, it's very difficult for it not to arise in these environments. We also developed a system of training where we taught staff how to safely intervene and restrain patients if necessary, in order to manage everybody's safety. But the real challenge was the culture. It was the environment. Our average ward typically had 48 beds, often were mixed sex, and often, certainly the ward I managed, I don't know if it translates, but in the UK, we used to call it the dump. It was where you threw all the rubbish. So I managed a ward that was full of patients that other wards couldn't manage. And so everybody on my ward was really challenging and difficult. It was just a horrific environment. And around that time, and mainly because of some of the work in Scandinavia, there started to be a global shift towards deinstitutionalization. A civil rights movement was gathering pace, and you know, both on a professional and social perspective, as well as a political perspective, everybody started to recognize these big asylums, hiding people away from their local communities, wasn't really a good thing. And the government in the UK initiated a hospital closure program. The hospital I was working at had a 10-year closure program. But again, we'd had 2 patients murdered, and then we also had a patient killed by a member of staff. A member of staff hung a patient on a toilet, not intentionally, I might add, but it was a common practice on some of the wards to take patients to the toilet and to tie the patient onto the toilet to keep them there, because we didn't have enough staff. And a patient had somehow managed to try and get off the toilet, but the way they'd been tied on the toilet resulted in the patient slipped and hung. So the hospital I was working at, instead of a 10-year closure program, it turned into a 2-year closure program. So there's a lot of focus on moving people out into the community, and this idea of a rights-based, recovery-orientated approach, bearing in mind that for some of the patients with an intellectual disability and mental impairment, it wasn't so much about recovery because they weren't ill. It was about enablement rather than recovery. So that started in 1990. And again, one of the challenges I mentioned at the beginning is it's very difficult to balance everybody's rights. You know, the public have a right for protection. They want to be safe and feel safe. But we also have to balance the individual's rights to live in the community, to at least have the opportunity to contribute like any other member of society. And for some patients, that's a really difficult balance. It's a very difficult judgment. And certainly in the UK then, and I would say still is the case, if you get the judgment correct, if you're able to balance the public's right to be safe and the individual's right to live in the community, nobody cares because it's seen as working. But for every 100 patients you get it right for, you make one mistake of judgment, you don't provide the right support to the individual, you don't make the right assessments. If that individual then goes on to commit a crime, and you may have seen recently, it was headline news in the UK, a patient with schizophrenia with a forensic history was discharged, was failing to liaise with community services, took a machete and killed two students in Nottingham. The patient hadn't been taking his medication, hadn't been turning up to meetings with the community nurse. So it doesn't matter how many times you get it right, our measure of success is only judged by failures. So it is very difficult for services to know how to do this. And particularly with forensic patients, or at least patients, like I say, they may not have come into contact with the criminal justice service, but we know that they're going to present problems in the community because of either their psychiatric or mental impairment, but they present lots of behavioral, and particularly, certainly the population I worked with, a lot of social challenges that were very, very difficult to manage. But the premise of which we set the community service up was we wanted to shift the culture first and foremost. We recognised that it wasn't staff actively abusing patients in the institution. It was the culture that created the environment to enable staff to abuse. I can't honestly say I ever went into work thinking I'll abuse a patient today, and I can't think of any colleagues who had their attitude, yet abuse occurred. So we were very careful to think about the environment and the culture in which we set the service up. So we put a lot of work into with the staff to focus on the service had to be a rights-based, person-centered and co-produced approach. We had to focus on the human element of what we were doing, and we had to focus on the staff and the patients being together first and foremost as people first, not the old staff versus patient. Because we really kind of were concerned that it's the us and them, and that, I have to say, isn't just an issue about hospital closure. If we look at the challenges politically across Europe and the world now, whether that's social challenges, religious challenges, issues about economic migration, if we look at what the media do, is they play a very good game of us versus them, because that fuels difference. And when you see somebody is different to you, their status is not equal, then it's really becomes quite easy for a good person to do bad things to somebody who's valued less. So that was a really key factor when we set up the service, and something that was really important for managers to take responsibility for, is to create the right culture in which staff supported people. So we had a very different look the service we set up looked like any other house in the UK. It was in the street like any other house where everybody else lived. We wanted it to be just like everybody else. The service was intensively supported. The first service opened in 1995. It was part of a wider service supporting over 200 patients, but 5 of the services were specific for people with a forensic history. We had 28 patients. It was nurse-led, very highly staffed, 24-hour residential support. We also had external support from psychology, psychiatry, community nursing teams. We set up a paid employment service. There was a local service called Employability, what was set up by the government to help people get back into work. They couldn't help us. We couldn't find any employers willing to take our patients, even into voluntary employment schemes. So what I did is, because we had lots of services in the community, we had a team of gardeners, we had a team of maintenance, painters and decorators who maintain the properties. So in order to give people meaningful occupation and employment, I set up a supported employment service. So each of the people in the forensic service were able to get paid employment with support. So they had a support worker with them all the time, making sure they turned up, helping them with the work. Because again, a lot of the patients had been in hospital for so long, they'd become institutionalized. They'd got a high level of learned helplessness. They just couldn't do anything, or didn't feel they could, were worried about failure. So that was another important element to support the residential side, not only because we know, if we keep people occupied, that's a really important aspect of keeping them in the community, but it gave people a sense of purpose, and also it gave them money, because they wanted to go out and to have some level of income that they could go and do the things everybody else does, whether that's go to the local pub, buying cigarettes, go to the cinema, have a social life. So that was a really important aspect. The other difference was every service was within 1 mile of the city centre. So again, it was easy for people to go to the local supermarket, to do the kind of things everybody else living in the city did, as opposed to previously 15 miles away from the city centre. You couldn't really walk anywhere. There was no local transport. So again, we selected the properties. We either purchased the properties off the open market, or in some cases we had them built specially. And none of the forensic services had more than 4 people sharing. So 4 was the biggest, 2 was the smallest. And the way it was set up is every individual had their own front door key, and then they had their own bedroom and ensuite, which the key opened. And then the lounge and dining room, there's like a communal shared area. And each person's key only operated the front door in their room. They couldn't get access to anybody's other room. It was important that everybody had private space. And also we ensured there was a room that doubled up as a staff office. And also we had staff who would sleep overnight to provide nighttime support. But essentially, people could come and go as they pleased. Sometimes staff would accompany them, sometimes staff wouldn't. It was really about helping people to live as independently as possible, but with the safety net that there was always staff present. Most of the patients transferred from hospital as part of the closure, but we also started to take referrals from other hospitals in other cities. But we also had a number of people who would transfer from prison, because one of the challenges we have, certainly in the UK, is some people with a mental disorder, with a mental impairment, don't actually end up in hospital. They end up in prison, and they are very, very vulnerable once they're in prison. So we did occasionally take people who were transferred from prison because of those vulnerabilities. We had mixed gender services. Some were single sex, but we did have a couple that were mixed genders. Sometimes that worked, sometimes it didn't work. Again, the challenge if we tried to keep each service to a single gender is there was the risk that we'd run with bed vacancies. And if we had bed vacancies, we couldn't generate the income to pay the staff, so it did have to operate as a business. So again, we tried to be flexible. A real challenge because, again, depending on the person's background and history, if there was a mixed gender service, we didn't take anybody who had a history of sexual offences because we didn't want to put anybody at risk. But I have to say as well, people with a sexual offence history, we still had to consider that carefully, even in a single sex environment, because the sexual offences could be related to a mixed gender or same gender offence. The commonality is everybody had to have a diagnosis of mental impairment with complex needs and typically had associated offending behaviour. The majority of people we supported, their history of offending tended to be physical assaults, some sexual assault, sexual offences. We had a couple of people who got firearms offences, arson, theft, quite a number of people who also had alcohol and substance misuse. And we had a proportion of people who hadn't really committed an offence. The best way I could describe it would be people who were seen as a social nuisance. They weren't really committing offences, but they would go into the local supermarket and just take things off the shelves and walk out. They would go into a local restaurant or bar and just cause problems, and the police would be called and the police would ask them to leave, but they would never get arrested as such. Or if the police did arrest them, they would take them to the local custody centre and the custody sergeant would refuse to admit them because it was clear that they had some kind of mental impairment or mental disorder. So again, they hadn't really gone into the criminal justice system, but they were troublesome. So we did have a number of people who didn't quite fit anywhere, and equally couldn't be accommodated, so couldn't get admitted under the Mental Health Act back into hospital, but couldn't be accommodated in other community-based services because they were just too problematic. I can't think of another way to describe them, but hopefully that makes sense, and I'm sure you can think of patients like that. The service had a 20-year success period from 1995. It was very, very, very successful. The levels of reoffending and readmission into hospital were extremely low. It was the ideal model. However, I'd left the service by then and I'd started to work for CPI. But unfortunately, it closed in 2015. The service itself, it still exists, but they no longer support people with mental impairment, complex needs, and any forensic history. They just stopped supporting people like that. And there were a number of problems that led to that. There's a mixture of apathy, and when I say apathy, the social and political climate in the UK changed after the 2008 financial crash. The government had to save money, and the best way they could save money was through social funding projects, and it didn't matter how successful the project had been. The commissioners who purchased the beds for each placement just didn't have the money to pay. And although it was successful, their approach was, oh, well, there's nothing we can do about this. And so they started to either withdraw the funding, or the other thing they started to do is to say to people, you could actually live in your own house and you don't need all the support. You've not offended now for X number of years. We think you could live in your own house. And the difference there is for somebody like that to go and live in their own home, the payment for that house comes from housing benefit. It's a different funding stream, so it saves the commissioners lots and lots of money. And so they started to do things like that. And there was a lack of what I call institutional memory. People had forgotten where the patients had come from and the offences that and the history of the patients, and they could only see the success, the here and now. And what started to happen is they were moving people out into their own flats, and lo and behold, people started to offend again and be readmitted into hospital. There were a couple of people who ended up back in prison, and that kind of history was lost because the people involved had changed over time, and the fundamentals was it was just too expensive. And the commissioners just couldn't afford it. You know, the government had run out of money because of the financial crash. But the 20 years when there was no funding issues, it was exceptionally successful. And the success factors were down to there was such a commitment when the hospital closure program was announced for all the different agencies to work together. We had to close the hospital. There was health, social care, housing. We had all the multidisciplinaries together. We were focused on what patients would be discharged where, what service was best, and how much that would cost, where the funding was coming from. Many of the placements were joint funding. The funding was shared across agencies, so it didn't sit on anybody's balance sheet. It wasn't down to health to fund it or to social care to fund it. It was everybody coming together. It was a perfect setting to create a really, really good service. Um, there was also a tiering of the service. Not only did we create the step down service into the community, intensively supported, but there's an agreed step back service. So one of the things we had, if we're having challenges with any of the patients, I could ring the local hospital up. The three large hospitals closed, the 2,000 beds closed, and that was replaced by a 60-bedded inpatient service, brand new, and then an 18-bedded assessment and treatment service. And what I was able to do is to ring the consultant on the assessment and treatment service, and I could simply say, we're having real problems with this patient. We could do with a temporary admission just to give everybody respite. Sometimes it was the dynamics because people shared a living environment, and maybe it was the relationships between each patient was breaking down. Sometimes it was a bit of the dynamic between the patient and staff. Sometimes there was a dynamic between the patient and the local community. So I was able to quickly get the patient back into hospital for a short period. We could do, if nothing else, it just took the steam out, like a respite to give everybody a chance to reset and rethink what we were going to do. Sometimes it was about, review the medication, review the support we're offering, and that was really critical. So that was critical to making this a success. It was very, very easy to get that support. Workforce training was really, really important as well. So again, we tried to create this culture of we. It was about the staff and the patients co-producing and supporting each other, a focus on human rights, person-centered trauma-informed recovery approaches. We had a very intensive training package. So the package that CPI now offer, we deliver to 18,000 organizations around the world. That was really critical. We had to make sure that staff had all the knowledge and skills to understand and support people with often quite severe challenges in their behavior. We had to make sure staff were resilient and could cope with some of the challenges that the patients presented. So a lot of time and a lot of investment in making sure our staff were really well equipped. and creating sustained and responsive leadership and support. We had a 24-hour support network with managers, and if a member of staff rang for help, we made sure a senior manager could be at that service within 15 minutes. It was really important that if staff were struggling, they knew they could call for help and somebody would actually turn up, not just give advice over the phone, but could physically turn up and be there with the staff, coaching, guiding, supporting, and leading the way. That was critical because we wanted staff to feel empowered, but we wanted staff to know when things were going wrong, managers would step in and be there with them. And we wanted to create a culture of reflection and learning, not criticism if things went wrong. And it's very, very difficult for staff. You know, if you think about it, I said the ward I managed in the hospital, 48 patients. We typically had six staff on duty, but the ward was vast, the hospital was vast. The staff could go off for a break, could walk down to the staff canteen, could sit and have lunch with a colleague, could go on a coffee break. In the community, in these services, the staff had nowhere to go. There was no canteen. There was nowhere to go get a break. The staff had a cup of coffee in the kitchen with the patients, with the service users. Lunch was cooked with the service users, by the service users. The staff ate at the table with the service users. So it was really important that staff felt supported and could speak openly about their stresses. I actually did a piece of research where I compared job satisfaction and burnout and stress with the staff still working in the hospital with the staff working in the community. I surveyed nearly 300 staff, and the results were quite interesting. The staff who remained in the hospital, the 60-bedded hospital, were highly satisfied with their job. Really satisfied. But they also had high levels of stress and burnout. They'd almost reached the point where, well, you know, this is how it is in these hospitals. You can't work miracles. Patients are detained. So they're almost burned out by that kind of lack of notion that they could achieve anything. But as a result, it was though they're quite happy with the job. The staff work in the community, it was interesting that they had very, very low levels of stress and burnout, but were very dissatisfied with their jobs because they still felt this notion of hospital closure and people moving into the community and integrating in the community. There were still barriers there, and staff were actually frustrated. And also staff were quite frustrated that they felt isolated. They didn't feel part of this big hospital community. They only saw a small number of colleagues in their own little service. So supporting staff both in terms of knowledge, skills, and just being there for them was very, very critical. Fast forward to 2025, it's not just that service that closed locally. I work with lots of organisations up and down the UK and around the world. What we're now seeing is that house that looks like your house and my house down the typical street in a typical town and city is being replaced by in what we call independent hospitals, and more so it's economies of scale, because again the financial crisis still exists in the UK. Government spending is 40 billion overspent, and the only way the government can save money is to cut funding for public sector services. So in terms of economies of scale, what we're seeing provider services doing is open larger services, larger units, because they can obviously drive the price down and it becomes more appealing to the commissioners. So we're now seeing 20-bed services quite common. Now, the only exception in the UK is the government has given a commitment to discharge everybody from hospital who's got a diagnosis of autism. So again, I mentioned earlier, I'm doing some consulting at the moment with a couple of services where an individual is living in their own home, often staffed 24 hours a day with up to 6-7 staff, and the cost of that service is over £1 million a year. But that is the exception. What we are seeing is these larger services of around 20 beds for people with complex forensic histories. Again, it's simply the cost. Some of the challenges that exist, not just financial, is, again, the landscape changed. So when the hospital I worked at closed, it was really true joint working, joint partnership, joint funding. What seems to be happening at the moment in the UK is there's quite a lot of dysfunctional working between all the different departments, whether that's health, the justice, criminal justice service, or the social care sectors. Everybody seems to be working in silos a bit more than historically they did when I was involved in the hospital closure program. And I think that's probably being pushed by the tightening of the budgets by the government. So there's limited resources. There's a lack of specialist services and accommodation. What's also happened is in the UK, when I trained as a nurse, I actually applied at the hospital. I was interviewed, and then I went into this nurse school in the hospital, and I was trained in the hospital. And because the hospital had 2,000 beds, not only through your training did you get lots of exposure and experience in different services, different settings, different patient populations. Once you qualified, it was unlimited. Now what's happened over time is all nurse training is in universities. Universities are not connected to services. Students get sent on placements. And I definitely think it's not just nurses. I think all the different professions now, they're leaving university qualified, but they're not really having the depth of experience across a broad range of patients and patient populations and needs. So not only are we being faced by limited resources, what we're seeing that the market, the workforce, don't seem to have the expertise either. And also what we're seeing is there seems to be a reluctance in the younger, newly qualified people to stay. Again, when I trained and qualified, people generally worked in the hospital for their entire career and then retired. You kind of, they kept you there. Now we're seeing professionals who they come, if they don't like it, they leave, they go somewhere else. If they don't like it, they leave. So professionals are choosing to go where they want and work where they want. So there's less of a committed workforce, certainly in the UK, and that's impacting on the provider services ability to provide high quality care. So it's a real challenge in the UK, definitely. There are also gaps in public protection arrangements. So there's a national public protection arrangement policy in place where multi-agencies should make those assessments. Sometimes those assessments are really, really good. And when we get it right, nobody cares. But you get it wrong, it's headline news. And unfortunately, you know, within a forensic environment, you are judged by your failures, not by your successes. And again, limited communication and engagement. And there's a lot of everybody wants to push it around. It's not for me to fund, it's for that service to fund. Nobody wants to kind of, like I say, take responsibility. Assessing and balancing that kind of public safety and individual autonomy, really, really difficult. At best, we could flick a coin and make a decision. We know from the research, making accurate assessments is something professionals struggle to do. Even if we use something like HCR 20, it's very, very difficult to get these decisions accurate. Continuity of care is incredibly challenging, and not only in terms of the service, but for the individual. once the individual moves from hospital into the community, trying to get the person to engage in the services, support, therapies, etc., can be a significant challenge, as is the ongoing risk assessment and management. And it's much harder now. So when I first set up the service, I literally picked up the phone, rang the consultant. I could quickly get the patient back into hospital. That's almost impossible now. The patient has to do something quite serious, because the service went from 2,000 beds to 60 beds, and those 60 beds are typically full. So even if you try to get a patient into hospital, there are no beds. And the patients in hospital are the patients in greatest need, because you have to be very, very ill in an acute state of mental health crisis before you can actually get admitted. And there's lots of pressure on inpatient beds. They just don't exist. So the landscape has changed significantly. There's also a stigma. The phrase, we use the phrase in the UK, we say NIMBY, which means not in my backyard. Everybody agrees that close the hospital, people should be living in the community as long as it's not next door to me. As long as it's not in my town or village, because I don't want somebody living next door to me who's got a forensic history. And we did have some challenges, and we had to do a lot of neighbourhood work, uh, you know, talking to local communities, talking to neighbours, reassuring them that they weren't at risk. Um, and there's a lot of resistance. There's a lot of resistance. If you take somebody with a mental health problem who's committed no offences, if you take somebody with autism or a learning disability, the community become anxious. The fear of what that person might do. If you add the label of forensic, and then especially if it's something like a sexual offence, then the levels of anxiety in the local community go through the roof, and it's really, really challenging. There are housing and limited support options, shortages. Again, certainly in the UK, there's a general housing crisis. For the likes of me and you, if we want a house, it's very, very difficult to get one, because the government haven't been building them. So again, to try and get the right housing to accommodate people being discharged out of hospital, it's just an added pressure. Uh, Serious lack of paid employment. The only way I could get people paid employment is I had to set the service up myself, and then the funding rules changed, and so the commissioners wouldn't fund that element of the support. So we had to find monies ourselves to try and pay people. So it's really, really challenging. And ultimately, the notion of social exclusion still exists, and that undermines everything. Um, there's the balance of ethics still, about how much do we try and ensure people live independently back into their community. There's an ethical debate that we should be doing that, and there's an economic debate whether the certainly in the UK, whether the government can afford it. There's always going to be the issue of balancing risk taking with risk management, and an innate instinctive response by staff to be risk averse, because again, we naturally worry about what if it goes wrong, rather than focusing on all the successes we have. I recall one patient we worked with. He got a history of sexual offences, alcohol and substance misuse, and the staff wanted him banned from all the local bars and restaurants so he couldn't have access to alcohol. Just ridiculously risk averse strategies, and totally unconnected with the patient and their needs and what would work for them. But that's a difficult barrier to overcome in staff minds. And the other barrier is the one strike and you're out rule. Just like you and me, your patients, your service users will not live a perfect life. They'll make mistakes. The difference is I haven't got a diagnosis, I haven't got a label, I'm not stigmatized. If I went out and got drunk, fell over in the street, and the police were called, so what? The worst that could happen is I would embarrass my wife and children. Uh, if it's one of your patients, one of my patients, then suddenly it becomes a big problem. Suddenly we're looking at the risk management plan. Suddenly looking at whether this placement is the right placement. So this balance of freedom and proportionate and lawful restriction is a real challenge. So again, we have to think about safe and ethical transitions for patients. It has to be a shared responsibility between agencies. Planning, coordination, and support are key. We have to balance all these legal, ethical, and moral issues. You know, it is a challenge to uphold people's human rights, and I can't emphasize enough. Even if you get all those things in place, strong leadership, effective, knowledgeable, skilled, and supported workforce are critical to success. And I'll leave you on this last point. So I've just visited and I'm working with a service. The person in question is 22. He has autism. He's been in long-term segregation and seclusion as a detained patient in hospital for the last 4 years. He has a history of serious violence. He now lives in his own house. His back garden has a 25-foot fence around it. The entire property is locked. You can only get in and out the property with special keys. It is staffed 24 hours by staff. Okay, so he's no longer in hospital. He's no longer subjected to seclusion or permanent isolation from anybody else. So in terms of the government, they've ticked the box. He's now living in the community. The cost of his service is £1.3 million a year. I would argue he's in a cage, no different than the hospital. It's just that the cage is gilded. It looks nice, it sounds nice, but he's still subject to isolation. And I think the real challenge is where the person is doesn't fix them. The complexities in the person in hospital are the same complexities when you move into the community. The person doesn't have a personality transplant, doesn't have a brain transplant, doesn't suddenly acquire social skills that they didn't have before. They remain the same person. A change of environment does not necessarily alter that. I would also argue that some of the risks potentially increase and it becomes even challenging for the staff to implement effective control measures because in the service that I manage, if the individual says, I'm going out, I'll see you tomorrow, I would say, okay, then make sure you've got everything you need and you've got the number. If you need any help, give us a call. What I couldn't do is say, you are not leaving. I had no legal right to stop the person from leaving. So controlling some of the risks become even greater. And also, I come back to my opening point. If there's an imbalance of rights, if the service you set up to support people in the community is based on a culture of us and them, poor practice will still happen and abuse will definitely happen. So the same challenges that existed in the institutions will exist in intensive community-based services. I would argue they'll be hidden to a much greater extent than they ever would have been in the hospital. So I guess my closing remark, and I'll take questions, is the service I was involved in was very, very successful. We had very few relapses, very few readmissions into hospital or prison. Some of the failures we had were despite our best efforts. And maybe, the person wasn't ready to take that step. Maybe we just couldn't find the right way to support them. It was very, very successful. And actually, the reason it fell apart wasn't down to the work of the staff, wasn't down to the individual. It was down to more the social, political issues. It just became too expensive. The government just couldn't continue to fund it. But whilst the funding was there, it was absolutely, for some of the people we supported, it massively changed their life for the better. So I don't want to leave you with a negative perception. For the people we supported, when the funding was there, when the support was there, it radically transformed their life for the better. So that's me. Happy to take questions.
Splendid. Thank you, Chris. I guess we have some time for, we have 4 minutes left. So yeah, what is the first question? Anybody can just raise the hand and ask question, or write it in the chat box. Until we get...
I have
okay.
a